Hello, and welcome to Let's Talk SADS Live, Canada. I'm your host, Shubhayan Sanatani, and I'm coming to you from Vancouver, where we're enjoying a rather warm morning. And so, welcome to our eighth edition of this webcast, and hope I'm reaching you somewhere enjoyable as the summer quickly is winding down. We're in that weather feeling a bit like back to school. The days are getting shorter, and we're starting to think about September. So delighted to be here today. Uh, this is really a privilege for me to interview our guests and to get to talk about SADS conditions. And really, all of us can come together and learn from each other. A place where we can learn collaboratively and learn from, especially some of the fantastic guests that we have had on this show. Now, there's a couple other things that we're doing here. You've heard me talk about our fundraising effort, and so the SADS board has been working hard at an auction, and I've mentioned it a few times now, and excited to be getting towards the go live in just over 5 weeks, and we're still collecting items. And how this works is you or your friends, your relatives, and I'm going to put a special challenge out to you. Many of you are patients or have physicians in your lives. Take this cause to them and see if they might support the SADS Canada Foundation to promote its educational activities. I was having a good conversation with someone the other day about the role of SADS, and I said, I really don't think there is another patient-driven support group of its stature in Canada and the U.S. and in many countries. We're of course very grateful to our Canadian board and our executive director Pam Husband, who got us going on this, and our American partners in this webcast, and Michael Ackerman and Alice Lara and Aaron, who help us behind the scenes as well as up front. So get your get your auction get your auction items to us. There's already some very cool things donated, and here are some specific things. And how it'll work is people will be able to bid on it. Terra gift card, and the people that wrote some cues for me, they thought I would need some help, so they didn't want me mixing up the Terra gift card and the Sophie Grace gift card. The Terra gift card is for a garden store, and the Sophie Grace is for women's fashion. And I guess they thought I might struggle with that because there's a plant in both of the slides. Um, there's some really cool looking golf out there in Cape Breton, and original piece of artwork donated by Andrea Pratt, and pedicure and spa gifts. And then some people have given just cash money, which is also good. Now, why does the Canadian SADS Foundation need money? Well, it's certainly not to pay my appearance fees, um, but organizing educational events and putting on even this webcast costs money. And our goal is hopefully to get a patient conference and promote some educational events over the next year. And so, even putting together a webinar and having those fees for hosting all adds up. Ultimately, we'd like to have even more educational activities and more patient support. So it does require quite a bit of fundraising. So I appreciate your support, and thanks for indulging me. The other thing I like to do on this series is talk a little bit about the Canadian side of things, and I've presented some interesting, fun Canadian facts. Most of these have been historical characters and events prominent in history. Tim Horton was last month's feature, and so today we're going to change direction a little. We're not going to talk about a person, and I wish this was an interactive question and answer, because I would say, what is this map showing? Um, And of course, it's not an obvious answer unless you're from the middle of Canada. This is Saskatchewan, which I think must be one of the only provinces
We
that
just need
has.
we just need the screen shared again. It's not onto the thing.
All right, let me go.
It should just press the present and then it should be in there.
Okay. All right. Thanks.
Yeah,
All
making sure.
right. Are we back there?
No.
Okay. How about that?
Yeah, there we go. Okay,
Okay.
you're good.
I
And
guess I guess I was talking too long without doing anything. So anyways, here we have this rather rectangular map, and for Canadians in the middle of the country, you recognize this as Saskatchewan, which I'm not sure if there's any other as regularly shaped provinces. But anyhow, why is Saskatchewan featured? Well, because I wanted to mention the Hospital Insurance Act, which is our fun fact, which came into effect in January 1947, which guaranteed every citizen of the province to have hospital care without a fee. And because we spend so much time talking about the cost of healthcare and some of the differences in different countries about healthcare, and Canadians pride themselves on our publicly funded healthcare. So I thought I'd go right back and say, well, where did this go? So interesting fact: January 1st, 1947, the Hospital Insurance Act. Now they were able to use user fees, which were eliminated later. But our fun Canadian fact is the Canadian Hospital Insurance Act. So today's guest, I have a great pleasure to introduce, and I'm showing a photo. This is probably around the time that I met our guest from today, Dr. Robert Hamilton. He was the attending electrophysiologist when I came to the hospital for sick children in the late 90s, and he was my mentor and tried to train me. Uh, it wasn't an easy task. And so it's with great pleasure that I am having him on the show today. And he's going to talk to us about Brugada syndrome. And a lot of his bio gives away some of the great science he's been doing. So I'm not gonna go over too much of that. He's originally from the Maritimes and did his electrophysiology with the infamous Tim Garson in Texas at a time when really that was the epicenter of innovative electrophysiology. So let's bring Bob into the studio and start talking about Brugada.
Hi.
All right. So now I hear a dog barking, which is probably at your end.
I'm afraid so.
And I
We
must,
having we're having doors delivered, and she likes to bark at the serviceman.
I, we must thank Bob for. You notice his background is not a fake background. He's actually on his holiday and kindly agreed to join us today. So really appreciate that. Um, now there's we've known each other for a long time, and I've been very impressed by your journey in science. I will say that Bob has always struck me as just one of the most clever research minds, and our conversations would quickly leave my understanding. So, uh, Bob, take us back about when you started looking at Brugada in a very different way.
Well, I'm not sure that I can pin down an exact date, but we've been interested in Brugada syndrome for a long time, not because it causes very often terrible problems in children, but because it causes quite difficult parents in the adults. And the adults always, they recognize that it's an inherited condition, and they want to know, will their children be affected in the future? Um, as you know, with arrhythmogenic cardiomyopathy, we got interested in looking for biomarkers rather than genetics, because in Canada, about 2/3 of ARVC in Canada is not identified to a particular gene, even though it may still be hereditary. It seems to be fairly gene elusive in a lot of families in Canada. And the same is true of Brugada syndrome pretty much worldwide. Only about 20% of Brugada syndrome is identified genetically. So it's hard to provide a gene test to families when 4 out of 5 families aren't going to have a result that helps them identify the members of their family that are affected. So we've been working on two things. We've been working on trying to understand what the EKG in children with Brugada looks like, even if they don't have a type 1 Brugada syndrome. And then we've been working on biomarkers across the spectrum of ages in Brugada syndrome. Yeah, so I mean, those are the two big areas of research around Brugada syndrome for us.
Yeah, and I, let's take it back a step, and the term biomarker is probably familiar to some in our audience, but what are you specifically talking about? Are you like a blood test or a piece of skin or?
Yeah, for us, it's a blood test. So particularly what we call a serum test or a plasma test, the clear part of the blood, and not looking at the genetics per se, but looking at other aspects of the blood, either proteins or, in our case, what we use are antibodies. I mean, one might say that's kind of unusual for Brugada syndrome, but when we we recognize that Brugada syndrome has inflammation, and so when we apply a broad test to look for antibodies in Brugada syndrome, we did indeed find 4 typical antibodies that always showed up in patients with Brugada syndrome. And in our controls, which were all kind of mostly white European controls, it didn't show up at all. So that's where we're at. We're trying to expand it a little bit more into other populations and see whether it can apply in other populations, but that's where we've started.
I tell the students and the learners that Brugada syndrome is one of the most confusing of the SADS conditions for me. Feels like every few months or once a year, someone writes this is a state of the art Brugada paper, and most recently people have been having some conversation about is it an abnormality of the way that the cells excite or activate, depolarize, or is it a problem with how they reset or repolarize? We know long QT, for example, is a repolarization abnormality. Do you have are you on one side or the other of this? I don't even know if it's a debate because probably no one really talks about it except real nerds. But has your work led you to understand what's going on in Brugada better?
Well, not at the cell level, but I'm aware of that debate, sort of the Arthur Vilde versus Charlie Ancelovich kind of debate that's been going on for many, many years. But you can take it and actually take both sides and make them useful. And so one of the things we're finding is very helpful is making a measurement of the depolarization and making a measurement of the repolarization, and then putting the latter on top of the former as a ratio. And so that gives you something that people like to call the index of cardioelectrophysiologic balance, which, thank God, we just abbreviate ICEB. And so the ICEB can be actually quite helpful in identifying patients who we think are predisposed to Brugada versus those that are not.
Right. So not to be confused with ICD, you've got the ICEB. And I've seen other sort of, mathematical interpretations of the Brugada ECG. So we have obviously mostly an electrical problem on the ECG, but yet somehow people are also finding structural disease. Like this is one of the few SADS conditions where you can go to the electrophysiology lab and someone, there's a few real centers of excellence. Someone can ablate your Brugada or burn away your Brugada. Have Have you come across that, or do you offer that, or it's probably more in adults, I imagine?
We don't offer that, but we've kind of taken advantage of that recognition in terms of guiding our science. So, although it's not done in North America, in one particular part of Italy, the investigators took biopsies from the inside of the right ventricular outflow tract, the area of the heart that's considered to be affected, and that's the area that's ablated from the outside of the heart. So, but they took biopsies, little pieces of tissue from the inside of the heart, and it was very interesting because the four molecules that we saw antibodies against in our studies of the clear part of blood, the serum, were exactly the same four proteins that showed basically clumping in the cells of those biopsies from the right ventricular outflow tract. So, obviously we need to do more experimentation and have more samples, but that's, where we've the association that we've shown. And so what we think is happening, and sorry for the noise, but what we think is happening is that these molecules are accumulating in the cells. The cells are trying to dispose of them, but somewhat unsuccessfully, and that what's kind of being thrown out in the trash is not fully digested yet. And so then these little parts of these proteins start to trigger immune responses when they get out of the cell.
Wow. All right. So, I mean, we've talked about, you mentioned arrhythmogenic cardiomyopathy, or ARVC. And it seems that in ARVC, we also focus on this area, the right ventricle in particular. And, people have found abnormalities in the right ventricular outflow tract. Some of your early biomarker success was in the ARVC population, I think. Is there any connection in the processes between ARVC and Brugada?
Well, really just inflammation, right? So that's why we went from one finding to the other. They're two very different diseases. So one gets you when you're exercising or under stress, and one gets you when you're sleeping. They're quite different presentations. But there are some overlaps, right? So patients with plakophilin mutations can sometimes present with more of a Brugada-like pattern. Patients with sodium channel mutations, which is a Brugada mutation, can sometimes present with more arrhythmogenic-like presentations. So mostly they're different diseases caused by, in general, a different constellation of genetic mutations. But there is some overlap, I think, and you can see mild structural abnormalities in a substantial portion of Brugada patients in the right ventricular outflow tract, whereas it's more typical in arrhythmogenic cardiomyopathies to see broader structural abnormalities affecting several areas of the right pumping chamber.
Yeah. So let's start talking a little bit about patients here. So, I mean, you and I, as mostly pediatric electrophysiologists, I personally, I don't have a lot of patients who have overt Brugada syndrome. Most of the referrals I get are from my adult colleagues. It seems to be a condition that affects predominantly males in their 20s and up. Now, one of our colleagues, Cecilia Gonzalez, who is one of our advisory board members, she's working on a registry, a pediatric registry. But do you have many kids with actual Brugada syndrome, or is it mostly referrals to rule it out?
Yeah, I mean, we probably have, a dozen that have Brugada syndrome. You have to remember that the way Brugada is defined, whether it's the best way of defining it or not, is by a type 1 Brugada ECG. So that's relatively rare in kids, but we do have about a dozen that have a type 1 Brugada ECG. And then we have, almost 100 patients where we've been referred the children for assessment because the parent, often the father, has been identified with a type 1 Brugada ECG, and the parent, often the mother, wants to know whether their child is going to have this. So that's what we've been working on, and we've taken a different approach. So we've kind of decided to look at the ECG in the children, and then we've used the dozen or so patients who have a true type 1 ECG to then look at all the other parameters on the ECG. And we use something that's sort of computer measured and gives lots of variables. So we use something called a measurement matrix, which is from the most common ECG machine. And it gives you about 170 measurements that you can, basically just copy over into a statistical analysis. And so what we do is we look at the dozen or so type 1 definite ARVC in children patients and say, okay, what are the other features of the ECG that define that? By comparing them to about 160 control patients that we've had from the school, from a particular school that volunteered to provide ECGs. So we have ages 5 to 15 for about 160 patients. And when we compare those two, we're able to come up with a set of ECG measurements separate from the type 1 ECG that differentiates them. So then we take that and apply it to the population of patients that are being referred for assessment, where the father has a type 1 ECG, usually the father, and the child doesn't have a type 1 ECG. And then we try to look at all those measurements together in something called a sort of a primary component analysis. And you can see that those separate into two groups, right, which are almost equal, which is kind of what you would expect for something that we think is inherited in a 50-50 kind of fashion. So we're also looking at patients, at families where there's a gene identified and trying to see whether or not these EKG parameters follow the presence or absence of the gene as well. So these are the ways that we're trying to come up with other ways of looking at children's ECGs to, differentiate or at least provide some statistical likelihood as to whether they do or don't have Brugada syndrome. It helps in a couple of ways. I think, it helps you sort of decide how closely you want to follow that child. But also it may help in terms of things like looking at segregation in a family where you haven't found the gene yet, but you're trying to identify which family members are affected so that you can go looking for a new gene.
Right. I mean, incredible stuff. And for a bit of context, so when Bob talks about 170 numbers from the ECG, most of us are looking at about 5 numbers on an ECG, if that, and we focus on one important one, the QT interval, which of course many of us are familiar with. So to actually break it down into 170 mathematical data points means you're really, you're doing a real sophisticated analysis of an ECG and looking for these subtle cues, which is just incredible. Now, recently there was quite a nice review about the use of sodium channel blockers. So I'm curious whether you do those tests. So this is a test where you might bring a child. So the child's father has Brugada syndrome, and you might offer them the option of coming in with their child to have in Canada, we don't have the access to the drug they use mostly in Europe, Ajmaline, but in Canada, we tend to use procainamide. I don't know if anyone's doing flecainide orally. I've certainly done some procainamide challenges, and then in reading this, the review, I'm not sure I know how to interpret even the results. Are you doing procainamide challenges in your center? Or?
No, we used to, but we didn't find they had much yield, particularly in, young prepubertal children. It may not be unreasonable to do in the older teenager, but we've not been doing them because we just found them not very useful. And reviewing the literature, we really just particularly in Canada, where your only agent is procainamide, we just found that there is some false positivity and there's tremendous false negativity.
So let's take a hypothetical 10-year-old who, in your clinic, father has a Brugada diagnosis, but he doesn't have a genetic marker. I don't know. I only really pay attention to the sodium channel marker mainly. I know there's other sort of things appear. The neurologists seem to find them all when they do these whole exomes on kids that have seizures. So there's no genetic marker. You have this 10-year-old child. You do your analysis, and it says, well, you have a tendency towards Brugada. You segregate with the Brugada markers on your ECG. What kind of treatments are you doing? That we can go extreme and say, back in the, when I was training, Brugada diagnosis Brugada almost meant a defibrillator automatically. We've come a long way from there. We've talked about over the years quinidine, but I feel like now even we don't tend to do very much. What's kind of your treatment algorithm for these patients?
Yeah, I mean, the problem with Brugada syndrome is that generally the risks in the patient that has not had an event, or in the patient that hasn't even had a diagnosis, are low. And so we've certainly not gone to ICD, and we tend not to go to quinidine, with the exception, I think it's very reasonable to consider quinidine, which has pretty good evidence for efficacy in adults in the patient who has a definitive Brugada syndrome with symptoms, particularly when you're trying to reduce defibrillator discharges and those kinds of things. So really, for the patient that you describe, child of a father with Brugada syndrome, we look at the ECG closely. We do a Brugada ECG, which is that, or sort of so-called high lead ECG, to try to identify, is there a Brugada pattern at higher leads on the chest? So moving up from interspace 4 to 3 to 2. And then I do a signal average ECG. I tend to find that the signal average ECG is positive, not in the same way that it is in arrhythmogenic cardiomyopathy, but the signal average ECG in Brugada syndrome often demonstrates some prolongation of the QRS, often in a relatively, what we would call a low frequency pattern. And then we basically, suggest to avoid fevers, have fevers seen and assessed early if the family's having trouble with treating fever. Find the source of fever early, all those kinds of things. And in a family that's affected by something like Brugada syndrome, where the individual risks are often 1 in 200 or less, then it's reasonable to think about the general preparations around low frequency but higher than average general population frequency events, of basically learning CPR, knowing where the nearest AED is. If the cumulative risk in the family is sufficient, then maybe arranging for a donated AED, particularly if you're traveling a long way from AED sites and EMS responses, those kinds of things. But really, I the event rates are so low that I recommend people that just come in for a yearly assessment and try to put it out of their mind in between. And then we recruit patients for research, of course. We're always very, very appreciative of those that want to participate.
Yeah, no, I'm thinking of your cabin right now when you say far from an AED, but hopefully you've had one donated there if you're remote.
No, I just take my chances.
And those are excellent points for almost all the SADS conditions, especially some of them, we don't we don't know as much as the patients would like us to know. So always having that, emergency awareness, it's sort of a balance between not living in fear, but also being prepared. And we're so matter of fact about being prepared in most of our lives in so many things. Like most of us will put seatbelts on in the car and, make sure our car tires are functioning and stuff. So it's just that similar mentality around your heart health. There's a list of drugs that, are mostly sodium channel blocking drugs, which thankfully very few children ever need to take.
Yeah.
And most of them are not of, it's nowhere near as onerous as the long QT list, which is known to the long QT groups. Activity wise, some people talk about, avoid exercising in the heat, pay a special attention to electrolytes and that. Are you doing any of that, or it's sort of carry on, your risk is so low?
Yeah, I certainly don't restrict families with Brugada syndrome. The events happen, in the late evening, early morning. They're not associated with exercise in the vast majority. There may be some exceptions, but in the vast majority, they're not associated with exercise. And I think, with all of these conditions, and I think you agree with this, we tend to exercise restrict, or we and our colleagues have over the years have gone too far in terms of exercise restricting patients. And what we're seeing in ARVC is, as soon as the diagnosis is raised, no matter how much we try to encourage the families, to not restrict patients who don't have a definite diagnosis in arrhythmogenic cardiomyopathy, that they start to become obese. And so Alison Howells just presented this, I think, at the European Pediatric Cardiology meeting this last year.
Yeah, no, there's definitely a lot of risks to a completely sedentary lifestyle, especially, as you say, events tend to happen, at rest in the night. And, sometimes, some studies have shown after a big meal or alcohol consumption. So, one of our audience is asking, what about a child who is at a young age and symptomatic? So as you and I both know, this is a fairly uncommon thing. Every once in a while, one of these situations pops up in the scientific conferences we go to, where someone will have, a 2-year-old or something who has a very advanced phenotype. Have you encountered many of those? Do you have some general principles? I mean, we talked about defibrillators, and quinidine.
Yeah, we have some experience between myself and my colleagues with, what Ron Cantor had called the Brugada-like pattern of infancy. I would probably extend that to call it the Brugada-like pattern of childhood. And so those are the severe ones. Sometimes they're homozygous mutations of sodium channel, so where you get 2 copies. Sometimes they're not. Sometimes they're just a really bad sodium channel change, presumably in that family or patient. Sometimes we don't identify a gene cause, and yet they seem to have this Brugada-like pattern of childhood, where they present in really severe arrhythmias. Their baseline EKG, even when they're not in arrhythmia, looks very abnormal. So in those patients, I think that defibrillation approaches are probably really important, but you have to sort out the timing of it, right? So in the, and if you think about it, your spectrum is going from really high risk of any kind of implantable a defibrillator, which would be in young infancy, and those risks continue on through mid-childhood, to epicardial devices, which have gotten better but still have substantially higher risks and morbidity compared to transvenous systems, and then transvenous systems as you get older. So, so when you try to implement those things, I think, the idea is, when are the different kinds of defibrillators effective? And I think AEDs are pretty effective when the subject, the child, and the parent are spending a lot of time together. So in early childhood, when the risk of implanted devices is highest, use of an AED is probably the safest option. As you get through to, older infancy, toddler, if your risks are really high from the disease, if you're having recurrent events, if there's sort of problems trying to take an AED, automatic external defibrillator approach, then we typically transition to epicardial devices, and they're not terribly difficult to put in. They do have a little higher risks and a little higher failure rates, but in the really, in the patient that really needs a device, then we would do that. And then there's this problem, in the intermediate risk patient, as they start into school age and beyond, that, you want to give them some kind of a backup treatment, but you don't really feel that they meet the risk thresholds for an implanted device. So that's a really tough decision between about 5 and 9 years of age, when and maybe even beyond that, right, depending on the risk. So if the risk is 2 or 3% per year, then you might want to treat them with some kind of an implanted device, and particularly once they get into those ages where they're not traveling with their parents all the time.
Yeah, that's one of the things in pediatrics, is you have such vastly different developmental stages that we deal with, and certainly as patients move through their progressive independence, we have to modify how we're doing things. I think the other takeaway for me is, none of us have a lot of complex young Brugada patients, so it's one of those conditions that it's always good to phone a friend and make sure you're dealing with people that are familiar with Brugada, and talking to the handful of people. It's great that there's a Canadian pediatric registry, and people, and Bob, you're doing amazing research on this, so it's things are in the works. One of my favorite sodium channel scientists, he's looking at some very interesting molecules, so I think the next 5 years could be very interesting in terms of what we might use for these sodium channel diseases. Bob, let me, in our last couple of minutes here, let me ask you just that future looking question. So do you see that your work may lead to something where one might be able to do a blood test in a newborn and say you will develop Brugada, or take me a bit of a tour of your vision for what's going to happen with your work?
Yeah, I think there's two sides of it, right? So there's the clinical side where, with the ECGs, although I don't think any company's going to, sort of say, okay, well, let's incorporate this algorithm into our EKG computer for the 1 in 2,000 patients that might have Brugada. I think what we can do is get the machine learning to identify the components of the ECG that are different in Brugada children, and then take what the machine has learned and try to translate that into the way that we look at the EKG. So as you say, we look at 3 or 4 or 5 parameters on the ECG in these children. Well, maybe we could look at maybe just 1 or 2 more, and maybe the machine learning and the research can help us figure out how to do that, and then maybe stratify who we want to see once a year or more often, and who we want to see once every 3 to 5 years or less often. On the biomarker side, what we're finding this year is that to a certain extent, it comes down to the populations that you're looking at. And so we published our original Brugada data mostly on European ancestry individuals, and now we're trying to stretch out into some of the other populations, that many of which have a much higher frequency of Brugada syndrome, right? So Southeast Asia and so on. And so what we're finding is that we need to take a look closer at the controls that we use for our studies, because they may be quite different from one population to the other. Then the last thing I would say is, even if we don't find the biomarker in terms of antibodies in Brugada syndrome, we may find it in proteins, or we may find it in a very interesting molecule called a circulating microRNA. And all of these can be measured in the same kind of samples. So we're using our samples to take a look for those things too. And we and others in Canada, including in Quebec, have been looking at microRNA in Brugada syndrome with some really interesting findings in both Brugada syndrome and in arrhythmogenic cardiomyopathy.
Yeah, I mean, again, as I said at the onset, I mean, your scientific curiosity is just incredible, and I really congratulate you on the work that you've done. Brugada syndrome is just one of the areas that Bob's been really making a difference. But he could have come and spoken about heart block, which is another immune condition affecting the fetus. He's done work in all SADS conditions. And just as we wrap up here, I will say, and probably I should have made this as our fun Canadian fact, it was Bob that introduced me to Pam Husband when I was in Toronto as a fellow with Bob. So here we are in some form of, maybe it's not full circle, some sort of crazy figure of 8 or something. But anyways, it's absolutely delightful to be able to chat with you here. And I thank you for taking your time out of your vacation to speak with us. And I'm sure our families and our audience are going to appreciate some of this. And also, I think just the knowledge that, people are really working on these conditions. It's in Canada, doing very good science and really cutting edge work. So congratulations to you and your team, Bob, and thanks so much for joining us.
Yeah, it's been my pleasure, and while I was looking for fun facts, I found one. I don't know if you know Avery, who was the person that discovered DNA as what transmits sort of genetic knowledge from one organism to another. Apparently, he was born and lived the first 10 years of his life in Halifax, and which is where I'm from. And do you know what the most famous quote from Avery is?
I do not.
Oh, so if you fall down, pick something up.
There you go.
Yeah.
Fantastic. Well, thank you. The added bonus there, a little Haligonian fun fact. So, Bob, I look forward to watching your science, and clearly you're a difference maker. And it was fun even to do a shout out to our dear friend Andrew Davis and his work on signal average ECG. I think you and I are the only ones still doing those things. All the documents are saying stop doing them. But all right, Bob, you enjoy, get back to your vacation and get those doors installed before the.
Yeah, my wife's going to put me to work. Always good to work with you, Shu.
All right. You take care. Enjoy the last few weeks of summer. Well, what an enjoyable conversation. It really is such a privilege to speak to this diverse group of people who are thinking about SADS conditions and doing research, looking after patients, and really working in service of improving care. And it's such a challenging journey. We talk about why does SADS need funds. Bob's paper in Brugada was a late breaking trial about 5 years ago. So it's very difficult work, very time consuming, very costly. So great to hear his progress. So I think that's all we have for today. We're back next month with, and it feels like we're going to have a back to school theme next month. September, even though, it's many years since I've gone back to school in September, you still get that sort of those butterflies in your stomach as Labor Day weekend comes up. And so I'll be really looking forward to speaking with you all then. And think about donating something to the auction. If you're a patient and you want to task your heart rhythm specialist with improving our auction, you can tell them I told you to do so. And stay safe, and we will see you next month.